Welcome to The Explainer. Today, we're stepping right into the clinic to uncover what is absolutely the gold standard of medical detective work. Just picture this. A patient walks into a consultation room. They've just discovered a breast lump. The stakes literally couldn't be higher, right? Getting that diagnosis exactly right is the single most important thing we can do. So how do we make sure we make zero mistakes? How do we build a completely foolproof diagnostic safety net? Well, that is exactly what we're going to unpack for you today.
Okay, let's dive right into this by looking at a number that might actually shock you a bit. 70%. If a clinician relies completely on just a physical examination, feeling the lump, checking the skin, taking a history, their diagnostic accuracy can be as shockingly low as 70%. That means on a physical exam alone, almost 1 in 3 patients could be misdiagnosed. And in the high-stakes world of breast pathology, a 70% success rate is, well, it's just not going to cut it. But here is where it gets super exciting. When we stop just relying on our hands and we start combining 3 very specific, distinct diagnostic pillars, that accuracy skyrockets to over 99.9%. We go from a pretty terrifying margin of error to effectively wiping out misdiagnoses entirely. It's this beautifully designed system that leaves absolutely nothing to chance.
So here's our roadmap for this explainer. First up, Pillar 1, Clinical Evaluation. Second, Pillar 2, Radiological Imaging. Third, Pillar 3, Pathological Evaluation. And finally, we're going to bring it all together with the concordance rule.
All right, let's kick things off with Pillar 1, Clinical Evaluation.
This is where the real, high-stakes detective work begins. Before we even touch a machine or look through a microscope, the clinician has to establish a baseline probability for the specific patient sitting right in front of them. And to do that, we start with history taking. Age is honestly the single biggest risk factor we have to consider here. A mass in a 22-year-old carries a drastically different probability, like a benign fibroadenoma, for example, than a mass in a 62-year-old, where we just have to assume it's carcinoma until proven otherwise. We're also actively hunting for red flags during this chat, things like rapid growth of the lump, spontaneous discharge from a single duct, especially if it's bloody, and skin tethering. And of course, we map out the family history, really zeroing in on early-onset breast or ovarian cancers in first-degree relatives that might point us toward those hereditary BRCA1 or BRCA2 genetic pathways.
Once the history is locked in, we move right to the physical examination. And this is a rigorous 3-step process. Step 1 is inspection. The clinician is looking for skin dimpling, nipple retraction, or any asymmetry while having the patient move their arms to contract the underlying muscle. Step 2 is palpation. Now, this isn't random. It's a highly systematic check of all 4 quadrants of the breast, plus the retroareola area right behind the nipple. And finally, Step 3, which you can literally never, ever skip, examining the lymph nodes. A thorough clinician is going to check the supraclavicular fossa and all 5 groups of axillary lymph nodes: apical, central, anterior, posterior, and lateral.
And this brilliantly illustrates what they're actually feeling for. During that palpation step, the clinician's fingers are hunting for very specific textures. When we come across a benign fibroadenoma, it literally feels like a marble under a rug. It's smooth, firm, and incredibly mobile, like it just slips right away from your fingers. But contrast that with a malignant carcinoma. That feels more like a rock embedded in hard soil. It's irregular, it feels incredibly hard, and most importantly, it's fixed. It doesn't move around easily because it's physically tethered to the underlying muscle or the skin on top.
But hold on, before we jump into imaging, let's just pause and consider a pretty terrifying clinical discrepancy. What happens if you do your history and your physical exam and the lump feels exactly like that benign marble? I mean, completely safe. But then, a couple days later, the mammogram comes back looking highly suspicious. Which one do you trust? Just keep that exact scenario in the back of your mind, because we are absolutely going to answer how to handle that discrepancy later in the explainer.
Okay, moving right along to Pillar 2. Radiological Imaging.
So now we're finally looking beneath the surface. But the tool we choose to do that is entirely dictated by 2 things: age and tissue density. This is literally the golden rule of breast imaging. If a woman is under 40 years old, or she's pregnant, our primary modality is an ultrasound. The radiologist is scanning for dark, hypoechoic masses, posterior acoustic shadowing, or a mass that is oriented taller than wide. However, if the patient is 40 years or older, the modality switches to mammography. And here, they're hunting for pleomorphic microcalcifications, spicular, which basically means star-shaped masses, and architectural distortion of the tissue.
Now, you might be wondering why that strict age cutoff at 40. Well, the biological why comes down entirely to the physiology of the breast. In women under 40, the breast is mostly made up of dense glandular parenchyma. And on a mammogram, dense tissue shows up as white. The problem? Tumors also show up as white. So, doing a mammogram on a younger woman just creates this massive whiteout effect, totally hiding potential lesions. It's like trying to find a snowball in a blizzard. Ultrasound, on the other hand, penetrates that dense tissue super easily. Conversely, as women age past 40, that glandular tissue undergoes fat involution. Basically, it gets replaced by fat. Fat shows up dark on a mammogram, which suddenly makes any white, suspicious masses exceptionally clear and easy to spot.
And regardless of whether we use an ultrasound or a mammogram, radiologists have to communicate their findings. So they use this universal language called the BI-RAD staging system. It gives a really clear, standardized score from 1 to 6. A score of 1 means the imaging is completely normal. A score of 4 means, hey, this is suspicious and absolutely requires a biopsy. And a score of 6? Well, that's reserved for a known, already proven malignancy.
Let's move to Pillar 3 and see how this all builds. Pathological evaluation.
We've felt the mass, we've imaged the mass, and now we absolutely must secure definitive tissue proof. Historically, there were two main ways to do this, but modern guidelines have a very, very clear preference. On one side, we have fine needle aspiration cytology, or FAC. It's fast, sure, but actually, its big limitation is that it only extracts free-floating cells. On the flip side, we have the core needle biopsy. This method uses a slightly larger, specialized needle to extract entire, fully intact columns of tissue.
So the crucial point here is why modern guidelines dictate that the core needle biopsy is the absolute gold standard. It's simply because cytology, just looking at those free floating cells from an FNAC, cannot tell you the whole story. A core biopsy allows the pathologist to actually evaluate the basement membrane. Because that whole tissue structure is intact, they can literally see if cancer cells have broken through that barrier. That means they can distinguish between a non-invasive ductal carcinoma in situ and an invasive ductal carcinoma. Plus, having that intact tissue column allows us to do immunohistochemistry testing. That tells us the tumor's receptor status. Is it estrogen receptor positive, HER2 positive? And having that information is absolutely mandatory for planning targeted oncology treatments later on.
Which brings us to the final piece of the puzzle. Section 4, the concordance rule.
Now we reach the real climax of this explainer. We have our 3 investigative pillars: clinical, imaging, and pathology. But honestly, having 3 sets of clues is completely meaningless if they contradict each other. And this brings us to the ultimate safety mechanism in breast diagnostics, the concordance rule. Listen, this is not a suggestion. It is a strict clinical mandate. It requires that all 3 diagnostic modalities point to the exact same classification. They have to align perfectly. Every single test must say benign, or every single test must say malignant. If they don't agree, the diagnosis is simply not complete.
When those outcomes actually do align, the path forward is crystal clear. We often call this the 1-1-1 rule. If the clinical exam is benign, the imaging is benign, and the biopsy is benign, that's concordant benign, it is finally safe to reassure and discharge the patient. Conversely, if all 3 come back malignant, concordant malignant, there is 0 delay. That patient goes directly to a multidisciplinary team for staging and definitive treatment planning.
But let's rewind and go back to that terrifying discrepancy we talked about earlier. What if the clinical exam felt like a benign marble, but the mammogram was highly suspicious? That is a discordant outcome, and the rule for a discordant outcome is a massive flashing red alert. Any discordant lesion must be treated as malignant until proven otherwise by an excision biopsy. You can never, ever let a normal-feeling lump or even a normal core biopsy override a highly suspicious mammogram. If even one single pillar flags danger, you operate and excise the whole lesion just to be absolutely certain.
So, to summarize our deep dive today, the triple assessment isn't just a checklist of 3 separate medical tests. It is a singular, brilliantly integrated safety net. By forcing the clinical evaluation, the age-appropriate imaging, and the definitive tissue pathology to agree with one another, it creates a system literally designed to ensure 0 misdiagnoses. It saves countless lives by catching what any single test on its own might miss.
Which leaves us with one final, provocative question to really test your grasp on the concordance rule. Imagine this. How would you manage a 45-year-old female patient who presents with an E2 clinical mass, meaning it feels entirely benign to your touch, but her mammogram comes back as a BI-RADS 4C, meaning it is highly suspicious for malignancy? Think about the safety net we just built today and what your next move absolutely has to be.
Thank you so much for joining me on this explainer, and keep learning.